Okay, so for today, we'll have the upper X sports rehab. No? So, I think this is your first asynchronous with me. So, yung isa lang sa mga pros dito is that if sakaling nabibilisan kayo or you would want to view it again, no, at least naka-record siya, pwede niyong balik-balikan. Okay, I think that yung upper X kasi, isa to sa mga dapat maganda yung grasp ninyo with the Terra X. No? Kasi a lot of PTs, especially yung shoulder, is one of the most complex, second most complex joint kasi siya. Okay, so in cases of sports rehab, it's very important to have a very good foundation of your kines. You have a very good foundation of how you assess, no? So M-evals. Alright, so let's start. Okay. Pag lagpas kasi natin ng shoulder, no, your elbow, wrist and hand injuries, more on ano na lang sila, spica. Okay? More on spica sila, okay? More on flexibility exercises lang, no? Not much of as complex as the program for your shoulder injuries. Okay, so medyo mag-focus tayo sa shoulder. Okay. In your shoulder, no, let's focus first on the dislocation itself. We have anterior and posterior dislocation. Okay. In your anterior, no, usually this is coming ang cause of or mechanism of injury or your MOI due to pitching, swimming, serving tennis or volleyball, no? Ganun kasi. Okay? Kung mapapansin nyo, di ba, ang ating mechanism of injury for your anterior shoulder dislocation is a bear. Di ba? Meron siyang abduction and external rotation. So, parang katulad talaga siya nung pag nagsaserve ng tennis and volleyball, no? Pagka volleyball, di ba? Pag magsa-spike, ganun. Okay? Maliban na lang kung yung pang beginners ka, yung ginaganon lang. Okay? Yan. Spiking volleyball, same din, no? Pag nagsa-spike ka, pag ganun din. Okay? So, usually, actually, yung mga volleyball players natin, they are the ones that, not volleyball players lang, no? Pero yung mga merong ganong movement, no? Abduction with external rotation, madalas sila magkaroon ng shoulder injury, not just the anterior dislocation. Okay? Overhead activities, no? Kapag masyadong, this is yung mga cumulative stress disorders natin. Okay? Dressing, combing, ayan. Hindi naman prone, no? Pero these are limited kapag meron kang anterior disloc. Okay? In your posterior disloc naman, these are your follow-through in pitching and golf. Mas mapipicture out nyo to when we discuss it further. Okay? Kasi i-discuss pa natin sila further in detail. Push-ups, bench press, pushing heavy door, pushing oneself up out of a chair or out of a swimming pool. No? Siguro ito yung mga medyo sobrang hina talaga, no? Sobrang fragile ng kanilang body, no? Ayan. So, let's discuss the anterior disloc, no? Your anterior disloc is one of the most common traumatic sports injuries, no? Like what I have said earlier. No, this is often associated with Bankart lesion, which is the detachment of anterior, ito makita nyo dito sa picture, no? Anterior or lower glenoid labrum. This one. Okay. Ayan. So, meron siyang detachment. So, that's your Bankart lesion. Also, no, pag meron kang Hill-Sachs lesion, okay. Hill-Sachs, nandito kasi ako nakatingin sa picture, no? Hill-Sachs lesion. No, when we say Hill-Sachs lesion, this is the compression fracture of the glenohumeral, the humeral head. Okay? Posteriorly. Alright? Posteriorly. Meron siyang compression fracture. Okay? Posteriorly. Alright? And then, you also have fracture of the glenoid rim or your bony Bankart. Okay? So, dun kasi siya sa glenoid rim ulit, no? Kung saan yung glenoid labrum mo, dun din naman, no? Nakasituate. Alright? And then, also associated with disruption of the glenohumeral ligaments. Okay? Glenohumeral ligaments. Okay? Especially your superior tsaka inferior glenohumeral ligament. Okay? Actually, no, yung foramen of weight breadth, kung maaalala ninyo, your foramen of weight breadth, this is the foramen or between the superior and then the inferior glenohumeral ligament. Okay? And this is the particular point of weakness in capsule. Okay? And ang nagre-reinforce dyan would be your subscapularis. Okay? Subscapularis. No? Siya yung nagre-reinforce dyan. Kaya kailangan pinapalakas din yung subscap. Okay? Kailangan pinapalakas din siya. Because this is your point of weakness in your GH capsule. Okay? So, these are the clinical presentation. No? There is an acute shoulder pain, feeling of the shoulder popping out. No? Kung makikita nyo dito in your OI, nakadepress na yung glenohumeral head. Okay? The humeral head, sorry. Humeral head, no? Nandito na siya nakadepress. And then, ito yung acromion. No? Yan, makita nyo merong pagitan. Okay? There's a prominent humeral head and hollow below the acromion. Okay? Usually, there is neurologic involvement, pero up to sensory lang naman. Okay? Up to sensory impairment. Alright? Okay. Kasi kung matatandaan nyo, there are nerves winding around the humerus, no? Especially your axillary nerve. Okay? Your axillary nerve, no? Umiikot pa kasi yan, si axillary nerve, kung maalala ninyo. Same with your radial nerve, although medyo malayo na, no? Hindi siya masyado nasa stretch. Alright? Si axillary, no? Kasi ano pa yun, umiikot pa siya. That's why we also term it as your circumferential nerve. Okay? Yeah. So, this is just a picture of the Bankart lesion. Okay? Ito yung labrum. Okay? Tapos, ayan, no? Na-detach siya. Alright? Ito, naligaw na picture, no? Meron tayong posterior disloc. Yung humerus, head of humerus is, was dislocated, no? Posteriorly. No? Mas posterior pa siya somehow from your acromion. No? Andito na siya. For anteriorly dislocated, ito naman, no? The humeral head sits medially over the scapula. No? Ito yung scap natin. Okay? Ito yung glenoid cavity. But, anteriorly dislocated humeral head, no? It sits medially. Okay? Yan. So, aside from dislocation, no, we also have subluxation. Now, what's the difference between your dislocation and subluxation? Dislocation, talagang nawala na siya, out of scope na siya from its articulation. Subluxation naman is more of, kumbaga, na-displace siya, pero somehow, andun pa rin siya along with its articulation. Kumbaga, kung ito, si glenoid cavity, okay, ito yung humeral head, okay, pag dislocation, talagang out of place na, no? Out of place na talaga siya. Pero pag subluxation, na out of place lang ng konti, pero somehow, meron pa rin silang dikit. Okay, may attachment pa din. Okay, so we have two for subluxation. It might be due to trauma or without trauma. Okay? Ang subluxation with trauma is purely due to injury. Kaya nga traumatic, no? Yan. It's unidirectional and somehow meron siyang associated or it comes with a Bankart lesion. Yun nga yung nakita natin sa picture kanina. Merong detachment of the labrum at the lower or inferior part of the labrum, no? And usually it is required to have a surgical intervention. Okay? But also we have subluxation without trauma naman, no? Usually if it's without trauma, okay, it is multidirectional, no? Hindi siya anterior lang,
Hindi siya inferior lang, hindi siya posterior lang, pero iba-ibang direksyon, no? Kaya siyang masablocks. Alright? And the, and usually it's bilateral involvement, no? Both sides. Okay? With this one, kaya siyang daanin with your rehabilitation, with your exercises. Okay? And yung inferior capsule shift is recommended. Okay? Usually, ito mga subluxation without trauma, these are due to patients who have generalized hypermobility. No? Like your Marfan. Okay? Ehlers-Danlos loss. Okay? Yan, may mga intense hypermobility talaga sila. Okay? Ayun. So, that would be for your subluxation. Okay? Let's go naman for your posterior. Okay. So, discuss natin muna paano tayo assess for this shoulder injuries. No? Pagka posterior naman, alright, this is less common than your anterior. Okay? Ang MOI niya kasi is direct trauma or FUSH. Makita nyo dito sa picture, no? FUSH. Diba? Kung maalala nyo si FUSH, okay? FUSH with a little bit of adduction and IR. Okay? Naka-FUSH, no? Pa-push ka. Okay? Ayan. Clinical presentation would be there is loss of normal rounded appearance at the front of the shoulder. No, yung normal roundedness, no, nawawala. And arm is held in IR and adduction. Okay? IR and adduction. Okay? So, ang cardinal sign niya, no, meron siyang limitation of ER. No, just like your adcaps, but then your adcaps, no, meron siyang rounded appearance. Si posterior glenohumeral dislocation, wala. Okay? Yun. So, suspicion of posterior dislocation is based on the MOI. No? Paano siya nagkaroon or bakit nagkaroon ng pain? Bakit nawala yung rounded appearance niya, no? So, you have to still have your medical history and thorough examination, no? Presence of pain and loss of function. Yung loss of function na to, meaning, limited ang kanyang ER. Tapos naka-adduct IR lang siya, no? Tapos acute pa. Alright? So, acute pa siya, no? So, automatically, maiisip mo talaga na, ay, hindi to adcaps. Kasi adcaps is chronic. Ito ay acute. Okay? And for sure, meron siyang traumatic cause. Okay? So, ganyan po yung nangyayari, no? This is your head of humerus, no? Tumalikod. In an antero-posterior x-ray, your AP x-ray, no? Makikita niyo that the humeral sits posteriorly to the scapula. Okay, ito yung glenoid cavity. Glenoid cavity, lumagpas siya, no? Lumagpas siya, no? It went posteriorly pa, yung inyong humeral head. Okay, so that's how your posterior glenohumeral dislocation is. Okay? So, some of the functional limitations for your anterior shoulder disloc is this one, no? Yan, no? Limited yan sa anterior shoulder kasi nga, ganyan siya, no? Right? So, we'll be discussing the throwing cycle. Okay, your throwing cycle is a kinetic chain that derives energy from the lower extremities, transferring it to your pelvis and trunk. Okay? So, pelvis with the trunk rotation and then releases the energy through the upper X. No? Diba? Kumbaga, para kang bumabuelo. Okay? So, i-divide natin siya into 6 stages. Alright? May wind up, early cocking, late cocking, acceleration, deceleration, and your follow-through. Okay? So, throwing cycle, yan po siya, no? So, during this time, no? Kumbaga, you are trying to prepare yourself. Okay? Prepare yourself and then, kumukuha ng energy coming from the lower X, going to the trunk. Okay? Transferring that energy from the trunk towards the upper X. No? Kaya minsan, no, sinasabi nila, well, hindi lang sinasabi, this is even according to researches. It is very important to have a good core. Okay? Even if you are exercising your upper X, but then you're not exercising your core, no, the transfer of energy is somehow not optimal. Okay? So, yung mga may good core, kahit mahihina yung mga upper X, lower X nila, feeling nyo ang lakas nila, no? Pero yun pala, it's coming from the core. So, very important siya. No? Anyways, let's have uh, the phases, no? Si wind up, no? Preparatory phase, there is body rotation. Kita nyo naman. Okay, body rotation. When the ball leaves the non-dominant hand. Okay, yan, no? Merong body rotation when the ball leaves the non-dominant hand. Right. Early cocking, ito na yon. Okay, the shoulder is abducted and meron ng external rotation. Okay, the body starts to move forward, okay, and generate the momentum. No? It terminates as the forward foot contacts the ground. No? So, yan yung early cocking. Okay? So, from here, no, makita nyo, ayan yung foot. Pag nag-land na siya, okay, dito, alright, once there is contact ground, once na nag-contact na siya sa ground, okay, yun na yung end ng early cocking. Okay, so ito siya. Late cocking, no, somehow medyo sila, talagang merong overlap. Okay? Your late cocking naman, body rapidly moves forward and the dominant shoulder achieves maximal abduction. So, yung abduction and ER mo kanina, hindi pa yun maximum. No? Sa late cocking siya ma-achieve. Alright? Yan. In your cocking phase, no, both early and your late cocking, no, you make use of the elbow flexor, supinator, your shoulder abductor, horizontal abductor, and maximal use of the external rotators, no? As well as your scapular retraction. Okay? Yun yung mga pinapagana nating muscle groups. Okay? Again, elbow flexors, forearm supinators, shoulder abductors, horizontal abductors, external rotators, and your scapular retractors. Okay, that's for your cocking phase. Both for your early and your late. No? So, if you want to address, no, yung mga patients who had injury due to this throwing cycle, yun yung gusto nating ipalakas sa kanila. Okay, that is what we would want them to strengthen. And then next would be the acceleration. In your acceleration, no, ito na po siya. Alright? There is an internal rotation of the throwing arm. Okay? From ER, no, internal rotation kasi ibabato mo na siya. Internal rotation of the throwing arm. And it ends with the ball release. Okay? In your acceleration naman, okay, it's more of the pronator teres, okay, triceps, okay, your pectoralis major, subscapularis, anterior deltoid, and serratus anterior. Yung apat na yun. Okay? And during acceleration, they are having a concentric contraction. Okay? Concentric contraction. Okay? During the acceleration. Okay? And then, yung follow-through natin, which is your deceleration, no, begins after the ball release, and 30% of time required to dissipate excess kinetic energy. No, syempre, kasi may momentum ka naka-momentum ka. So, follow-through or your deceleration, yun na yung you try to control the upper limb. Okay? With the excess kinetic energy. So, dito naman, the muscle groups that you were using during the acceleration, sila ulit yung activate dito, no, sa deceleration. Alright? Deceleration ito. Medyo, overlapping sila ng mismong follow-through. Alright? In your deceleration, it's more of, eccentric contraction. Okay? Eccentric contraction of those same muscles used during the acceleration. Okay? Lastly would be your follow-through. Okay? In your follow-through, no, the remaining 70% of the time required to dissipate excess kinetic energy. Ito siya. Okay? All major muscle groups are eccentrically contracting, no, to accomplish this result. Okay? And ends when all motion is complete. No? So, yung eccentric contraction happening in the deceleration continues up until your follow through. No? So, usually, nagkakaroon tayo ng uh, injury in your cocking phase and then during your deceleration or follow through phase. Okay? So, during those times, no, nagkakaroon ng tear, strain, muscle strain, no, if a patient comes to you na ito, according to their MOI, ito yung nangyari, no, it might be because merong tearing dun sa muscle to. So, next time, no, in your rehabilitation program, no, you would want to strengthen those muscle groups. Okay? Yan, no? Yan yung mga functional limitation during the anterior shoulder disloc. Okay, spiking, serving, no? Yung tennis ball serving. Okay, combing. Okay? Kasi yan, pag nagsuklay, no? Although yung picture medyo, ano siya, no? Misleading. Okay, combing, ganon. And, meron ka abduction, external rotation. Okay? Yan kasi more on IR, no? Pag ganon. Okay? Ayan. For posterior shoulder disloc, no, itong mahihirapan ka. Okay? Adduction and IR. Hindi ito yung isa, yun. Okay, ito. Adduction and IR ang limited in your posterior shoulder disloc. No, once na na-identify niyo yan, no, sa patient, sorry, let me correct that, no? Ang limited is ER. Okay, limited ang ER. Adduction and IR, ito yung tendency ng patient na i-favor niya na motion. Okay, kasi doon siya mas nare-relieve ng pain. Okay, adduction and IR. Alright? Adduction and IR. Same as here. Okay, sa follow-through, no? Ito, follow-through yan. Okay, adduction and IR. Alright? Yan. So, functional limitation. Functional limitation din nila yan. Okay? Yung throwing. Okay, if you have posterior shoulder disloc. Push-ups, no? Hirap din sila. Okay, push-ups, and then your bench press. This is what we call your bench press. Another limitation, no? Getting out of the pool and getting out of the chair. Okay? Yan, mga hirap yung ating patients who had posterior shoulder dislocation. Okay? Now, in your glenohumeral dislocation, no, if it's anterior, no, relocation or reduction is done with traction in forward flexion, okay, slight abduction followed by gentle IR. Okay? Yan. Or, what they do is, they prone the patient, sedate, and allow the injured arm to hang from the bed with the 5 to 10 pound weight attached to the wrist. Okay? Kasi the sooner the dislocated shoulder is reduced, no, or you have trinay na somehow ma-approximate siya dun sa articulating surface, no, the easier it is to usually reduce the dislocation pa. Okay, mas madali siyang ibalik, no, rather than matagal siyang nakadislocate, tapos a little later pa siya bago i-try ibalik. Okay? Yung sedation na sinasabi dito, no, there are a number of our medications that could sedate the patient, no. One med that they use is the injection of the xylocaine, okay, into the joint, okay, para lang ma-reduce yung pain and yung muscle spasm mag-reduce din, okay, and para syempre ma-aid yung reduction, no. Mahirap mag-reduction, gumawa ng reduction technique kapag ang patient is in pain, no. Yan siya. For this situation, no, sling, yung naka-ganon, okay, sling should not be used, no. According to studies kasi, no, when the arm is held in IR, no, which is seen during yung nakasling si patient, no, yung Bankart lesion that is associated along with the dislocation, it worsens. Okay? It becomes more detached from the bone. Okay? Mas nade-detach siya lalo. So, mas mahirap siyang i-ayusin, no? And kung maalala ninyo, you would have to have a surgical intervention for that. Okay? So, if ever, no, naman na minor lang ang lesion kay Bankart, na-address siya agad, hindi niyo siya place into a sling position, okay, it can be restored by placing the arm in ER. Okay, i-ER niyo lang siya, pero syempre masakit yun sa patient eh. Okay, masakit yun sa patient. Alright, so, you would have to really have a pain medication injected or orally taken, although medyo matagal ang peak hour ng oral meds. So, mas prefer nila ang ini-inject na. Okay? Ayan. So, ito yung techniques na yon, no? Yung naka-prone ta sinesedate. We call it your Stimson's hanging arm technique. Okay? Ito siya. Stimson's hanging arm technique. Yung relocation or reduction technique, that's your upward traction or overhead method. Ito naman yun. Hindi lang masyado kita sa hindi lang siya masyado kita. Alright? Pero yan yun. Yung reduction technique or your overhead method. Okay? Okay, next. Okay? In your anterior disloc, no, the active external rotation is allowed to start 3 weeks post-injury. Okay? 3 weeks post-injury. No, extensive exercises should be given to strengthen the internal rotators. Okay? Bakit? No? Kasi sila yung they are the ones who would have an eccentric contraction during the time that you do the throwing. Okay? Yun. Para hindi sobra-sobra yung pagka anterior displace of your humeral head. Okay? So, in anterior disloc, we give exercises to strengthen the internal rotators. Okay? So, the combination of abduction and your ER must be avoided for 6 weeks. Okay? So, yung MOI mismo should be avoided. Okay? Yung antagonist dun sa ating MOI, yun yung papalakasin during the rehab program. Okay? Ayan. Tapos, following a Bankart repair, no, if it was surgically repaired, no, either by open surgical procedure or arthroscopy, no, patient may commence pendular movement of arm within 24 hours, no? Para kang yung sa Codmans natin. Okay? Puro ganun-ganun lang muna. Okay? And then, you would have to maintain the arm in the sling for 3 to 4 weeks, no? If nabalik na yung Bankart, ha? Okay, kasi the only thing that is holding us back, no, from allowing the patient to have the sling is dahil nga yung Bankart lesion. Pero pag naayos na siya, okay, pwede na mag-sling si patient. Okay? About 3 to 4 weeks. Alright? So, in a splint, no, pwede na siya in somehow abducted and naka-ER. Okay? Abducted and naka-ER. Alright? Yan. Pero this is after the arm sling na. Okay? After the arm sling na. And then, return to full sports would be within 3 to 4 months. Within 3 to 4 months, kayo as PT would have to set a goal. Okay? To strengthen the internal rotators. Okay? Strengthen nyo pa rin naman ang abductors and ERs, pero minimal lang yung emphasis natin sa kanya. More on the internal rotators. Okay? Yan. Now, for your posterior naman, no, shoulder is reduced by applying traction forward, okay, and forward pressure on the humerus. So, parang ipupush nyo lang siya. Okay? Katulad dito sa picture. No? Ayan. Traction is forward with a forward pressure on the humerus. Okay? Yan. So, kailangan may forward pressure. Dapat ang force would be directed anteriorly. Okay? Directed anteriorly. Ayan. However, no, sometimes nauulit siya. Okay? In this location na yon, nauulit. Alright? And we call that your recurrent shoulder instability. Okay? Recurrent shoulder instability. And the etiology behind, no, kaya daw siya nauulit is the repeated overhead activity, history of recurrent dislocations. That's the etiology. And causes, no, would be lack of control. And dito papasok yung importance of a PT. No, maayos man siya surgically, pero hindi naman maayos yung mismong programming of the muscles, the proprioceptors, the muscle memory. Okay, hindi siya naayos, babalik lang ulit at mag-cause ulit siya ng dislocation. No? Kasi si patient, kaya siya nagkaroon ng, kaya niya na-dislocate yung shoulder niya is because nasanay siya ng ganong movement eh. Okay? Kung ano yung nakasanayan niya, yun at yun ulit yung gagawin niya. So, it's very important along the rehab program, lalo na pag malapit na siya mag-return to sport, is magkakaroon ng training si patient wherein you would simulate the uh, the activities ni patient, no, as an athlete. Okay, kung athlete si patient, no? And then you would practice the control. Okay? Yan. So, diyan kailangan, no, ang static stabilizers, no, somehow ito depende na sa body of the patient. But the dynamic stabilizers, the muscle tendon unit, and the sensory motor, no, kaya nyo yan i-incorporate sa rehab program ninyo. Okay? Ayan. So, we have TUBS and AMBRI. Okay? These two are actually the force required to create the instability is yung sa TUBS. Okay? In your TUBS, this is traumatic, unilateral, or unidirectional, okay, Bancart, and surgery. Okay? So, ang correction nito is through surgery. Okay? Through surgery. Okay? If you are having a recurrent shoulder instability, okay, we have two approaches, yung TAMS and yung AMBRI. So, sa TABS, no, traumatic, unilateral, or unidirectional, Bancart, and surgery. Pag AMBRI, no, mas prefer to according to researches, mas okay daw ang AMBRI, no, mas effective siya. This is atraumatic, multidirectional, bilateral responsive, okay, to rehabilitation, or surgically, an inferior capsular shift. Ito yung sinasabi nating inferior capsular shift kanina. If ever nagkakaroon siya ng recurrent shoulder instability, no, kung marirecall nyo sa kines, no, na for sure na topic nyo ito, no, and in your PT3, alright, na topic nyo na to, alright, in your AMBRI, no, you make use of the inferior capsular shift para hindi na siya magiging unstable. Okay? Ayan. So, what are the symptoms for recurrent shoulder instability? No, it would be weakness, locking, transient giving way of the shoulder, and dead arm. No, dead arm yung parang mabigat yung buong arm ni patient. Okay? Physical examination. Right? Okay. So, for the physical examination, right, meron tayong anterior instability, posterior, and multidirectional. Okay? In assessing kung anterior ba siya, posterior, or multidirectional, no, we can make use of the apprehension augmentation relocation test. No? Yung nasa picture dito, ito yung apprehension augmentation relocation test. No? So, ang ginagawa natin dito, in your apprehension, the first picture is apprehension test. Okay? Yung second picture, siya yung relocation test. Alright? So, ang gagawin, patient is in supine, as in the picture. Abducted ang arm. Okay, with external rotation up to 90 degrees. Okay? Positive siya if the patient feels as if nagsislip out yung humeral head. Okay? And hindi lang pain, no? Hindi lang pain. Okay? Feel niyang nagsislip out. Alright? Yun na. So, in relocating that, no, kasi syempre, pag na-feel niya na nagsislip out, ibig sabihin, nagsasablocks na yun anteriorly. Ibig sabihin, meron siyang anterior instability. Okay? To further strengthen that, no, na meron siyang anterior instability, you do the relocation test, no? Kasi syempre, sinablocks niyo siya forward, eh. Okay? You would have to do the relocation test. Itong, letter B. Okay? So, ang gagawin dito, you just posteriorly direct the force. Okay? Para lang bumalik yung humeral head back to the glenoid cavity. Okay? Siya. So, that would be for the anterior instability. Pag posterior instability naman, meron tayong tinatawag na marked posterior drawer test or your Miniasi, no? Ang gagamitin natin dito would be your Miniasi. Si patient naman still in this position, okay, nakasupine siya, pero instead na naka-abduct ER, kabaliktaran, no? We adduct and IR. Okay, adduct and IR. Alright? While ina-adduct and IR niya siya, alright, yung while you are directing that force, the other hand of the PT is at the posterior side of the shoulder. No? Papakiramdaman mo kung merong nagsablocks posteriorly. Okay? If you felt that there is a subluxation posteriorly, okay, that would be positive na. Okay? So, paano siya mababalik? Slowly, no? Slowly. You horizontally abduct and i-external rotate. Okay? And then, magka-clunk na siya pabalik doon sa glenoid cavity. Okay? So, pagka-positive si patient doon, posterior instability meron siya. However, it is possible kasi, no, na meron kang multi-directional. Okay? This is possible for patient who have, yun nga, hypermobility issues. No, ito yung kung saan positive siya sa anterior, okay, positive siya sa posterior, positive siya sa inferior. Tapos merong sulcus sign. No? Pagka inferior laxity naman, nakikita nyo, may sulcus sign siya. Okay? Yun. So, ano yung gagawin? Alright? If the direction of instability, okay, is anterior, no, the position to avoid is combined position of your aber. Okay? Kasi siya yung MOI natin. Okay? Pag posterior naman, position to avoid would be internal rotation, horizontal adduction, and flexion. So, parang, kumbaga, IR, no? Horizontal adduct, flex, and IR. So, pagka meron kang posterior disloc, bawal kang mag-hug. Di ba kasi yung hugging, di ba? Combination yan ng flexion, horizontal adduction, and internal rotation. So, bawal mag-hug si patient. Nakauwa naman siya. Pag meron siyang posterior instability. Okay? Pag inferior naman, okay, full elevation and dependent arm bawal. No? Kasi syempre, by the pull of gravity, no, kumbaga, kung may laxity dyan, no, mapupull lang downwards yung arm further. Okay? So, exercises, okay, to be modified or avoided. No? Imo-modify nyo siya if it produces the positioning or motion that is listed here at the second column. Okay? So, ano-ano ba yung mga exercises na yun? Okay? First is your fly. Okay? Ayan. No? Yung paganyan. That's your fly exercise. Okay? Bawal si patient dyan pagka meron siyang anterior disloc. Okay? Pull down. No? Ayan. Yung mga pull down exercises. Actually, maraming modifications to, no? Puro pull down. Alright? So, kailangan hindi ka magproduce ng abduction and ER. No? So, ito, pwedeng yan yung modification. Kasi ito, flexion, Okay? And then, naka-IR siya. Okay? Naka-ER pala siya, no? So, might as well, no, i-grab niya ng other way. Okay? Dapat naka-IR. Okay? Yan siya. Although, the cons para dito, no, syempre, iba yung mata-target na muscle ni patient kasi iba yung positioning niya. Okay? And then, we also have the push-up. No? Push-up, yung sa, yung kanina, may picture tayo kanina. No? Alam nyo na yon push-up. Etong picture na to kasi, this is your bench press. Okay? Bench press. Bawal si patient dito. Okay? It would further dislocate the shoulder anteriorly. Okay? Bench press. Military press, eto naman siya. No? Kanina nakahiga, ngayon nakatayo na. No? That's your military press. Bawal din si patient. Okay? Military press. Okay? In your posterior, no, almost, may mga, the same lang, the fly, push up, bawal, bench press, and your weight-bearing exercises. Okay? Weight-bearing exercises. And then, for the inferior, shrugs, no, yung shoulder shrugs, bawal. Okay? Yung curls, bawal din. And the military press. Okay? Bawal din si military press. Okay? So, yan yung mga i-avoid ni patient. In your anterior shoulder instability, no, arm should be placed in ER of 30 degrees for 3 weeks. Okay? ER of 30 degrees for 3 weeks. No? Di ba kanina, sabi natin, bawal muna siya sa aber. Alright? Pero, pwede if it's within 30 degrees lang. Okay? Pwede siya for 30 degrees. And then, for the therapeutic exercises, we will include, no, strengthening of the dynamic stabilizers, no? Ang mga key muscles natin dito is your serrats. Okay, serrats. Your mga na-discuss natin na scapular stabilizers, no, your rhomboids. Okay? Yan. Yung mga yon. Alright? Yung mga na-discuss natin na scapular stabilizers last week, sila din ulit ito. Okay? Yan. And then, we would have to have a posterior capsule lengthening. So, alam nyo na paano mag-stretch ng posterior capsule. Once na may clearance na ng physician, you can do the stretching of the posterior capsule, which is yung horizontal adduction. No? Kung maalala nyo. That's the one. Okay? And then, for your posterior shoulder instability, no, this can be treated by posterior stabilizing muscle. Okay? Posterior stabilizing muscle. So, talagang dito dapat you have a sound knowledge of those muscles, no? So, kind of may review kayo ng kines and foundational knowledge of your anatomy. Okay? So, review na sa mga scapular muscles. Okay? In your multidirectional naman, okay, treatment includes ganun pa din, no? Strengthening of shoulder stabilizers. Okay? In your multidirectional, dahil nga hypermob na si patient, no, syempre, stretching should be avoided. Okay? Hindi na niya kailangan kasi nga hypermob na yung patient natin. Okay? Next. Okay? So, kung mapapansin nyo, in shoulder problems, alright, more on scapular stabilizers talaga tayo. No? Very important na ma-stabilize ang ating scapula. No? Kung mapapansin nyo, yun yung parang pinaka-grasp natin dito. And then, you would just have to be familiar kung ano yung mga positions to avoid. Okay? Now, let's move on to the AC. Okay, AC dislocation naman. This is direct blow on the posterior aspect of the acromion and spine of the scapula. No, ang MOI na to, usually, player falls on the tip of his or her shoulder. No, kung mapapansin nyo dito sa picture, no, hindi, yung, pag titingnan nyo, walang symmetrical tipping of the AC here. No? Ayan. So, kung mapapansin nyo, the distal end of the clavicle, okay, on the left side here, is lying superior to the acromion. Nandito siya, oh. And then si acromion naiwan dito. Okay? Ayan. Alright? In your physical examination with AC disloc, no, there is an obvious depression of the scapula. So, kung nakatalikod si patient, may kita nyo, no? Kailangan marunong kayong test for the scapula, no? You would ask the patient to do certain motions, no? And you would have to palpate the whole scapula and susundan nyo yung motion. Okay? Titignan nyo kung equal ba sila yung may symmetrical motion ba na nangyayari. Okay? Or baka mas depressed yung isa, nalilate yung isa, tas yung isa grabe yung rotation, tas yung isa minimal lang. Okay? Those kailangan yung ma-observe if ang patient ninyo meron siyang shoulder problem. Okay? Or upper X problem. Okay? Localized tenderness to palpation. Okay? Meron siyang elevation of the clavicle and limited ang kanyang active shoulder range of motion. Limited. Alright? So, ito yung MOI. Usually, ganyan yung nangyayari. Direct fall on the point of the shoulder. Usually, sa mga rugby players, yung football, okay, sila yung mga madalas mahulog ng ganyan. Okay? In X-ray, ito yung makikita nyo. Okay? Ayan. So, in this X-ray, meron siyang combination of anterior shoulder dislocation and then step deformity. Okay? So, let's talk about the AC dislocs classification, no? We call it your Rockwood classification. Right? Si Rockwood classification, meron siyang overall, 6 types. Type 1, 2, 3, 4, 5, 6. Okay. So, for your grade 1, ang pinaka-highlight lang natin dito, itong mga naka-fold, no? In your grade 1, you have sprain of the AC ligament, the one that connects your acromion to clavicle. Okay? May sprain pa lang naman. Okay? But still intact. Alright? The coracoclavicular ligament, the one that connects your coracoid process to your clavicle is intact. Okay? Intact siya. And dito, merong minimal to moderate tenderness to palpation. Okay? So, yun. Basically, ang pinaka-problem natin dito, sprain of AC ligament plus merong tenderness. Okay? Siyempre, in every sprain, merong tenderness. So, given na siya. In your type 2, okay, the AC joint is disrupted. Okay? Disrupted na siya with tearing of the AC ligament itself. Okay? With an interspace of less than 4 mm. Okay? 4 mm. Right? Pero, yung CC ligament, na-sprain na din siya. Okay? CC ligament is sprained. Pero, intact pa din. Okay? Your deltoid and trapezius muscle, still intact, Nakakonect pa rin sila dun sa distal clavicle. Kung maaalala ninyo, di ba, meron silang attachment to, may attachment ang deltoid and trapezius muscle into your distal clavicle. Okay? In your type 3, both your AC and CC ligament is disrupted na. Okay? Both of them. And the shoulder complex is displaced inferiorly. Alright? Okay. Tapos, dito, masakit na siya in shoulder abduction. So, in your assessment, although hindi nyo nakikita to, yung mga, yung mga tear, hindi nyo siya visibly makikita. Pero, makita nyo that the pain is aggravated during shoulder abduction. Tapos, meron siyang tenderness. Okay, to palpation, most likely there is a problem with the AC joint na. Okay, and pag shoulder abduction masakit, ay for sure, meron na siyang tearing of the AC and CC ligament. Okay. Type 4. Okay, clavicle is displaced posteriorly. Okay, so ito pwede nyo tong mapalpate. Alright. AC and CC is still disrupted and, the deltoid and trapezius muscle is detached from distal clavicle. Meaning, pagka nag-assess kayo and you saw that the clavicle is displaced posteriorly, then that just means that the deltoid and the traps have detached already from the distal clavicle. No, yun yung gusto kong ano nyo dito. Okay, ma-take away nyo dito. Alright? Ayan. So, hindi lang to basta-basta um, knowing or memorizing the types, no? Pero kasi, in your assessment, no, basta masakit, okay, we would, as much as possible, we would want to know gaano ka-severe yung nangyari dun sa patient. Okay? Grade 5 or your type 5, no, there's a vertical separation of the clavicle, inferior displacement of the upper extremity, okay, and very prominent ang appearing ng clavicle. Okay? Tapos, meron na siyang pain on distal half of the clavicle. No, meron na siyang pain on distal half of the clavicle. Alright? Yung pinaka last natin will be the type 6, no? Clavicle is dislocated inferiorly under the coracoid process. Okay? Ayan na siya. No? So, sa grade 5, no, tumaas. And then, nag-bounce back pababa. That's your grade 6. Okay? So, what does it mean for us? Now, in your grades 1, 2, and 3, these injuries are treated conservatively. Ibig sabihin, pwede pa natin siya i-treat sa rehab. Okay? 1, 2, and 3. So, dapat alam na alam nyo kung paano yung staging, paano nyo di-distinguish different symptoms, signs and symptoms sa grades 1, 2, and 3, 4, 5, and 6. Okay? Pagdating sa 4, 5, and 6, it requires ORIF na, no? Yan. So, hindi na natin siya pupwedeng sa rehab lang. Kailangan na talaga siya ng surgical intervention. Okay? During your rehabilitation, you would focus on pain reduction with the use of sling, modalities, and restoring functional ROM. Okay? Excessive compressive force at the AC joint should be avoided. No? Yung excessive compressive force at the AC joint, usually this is this happens during extremes of shoulder abduction. Okay? So, very important din dito, no, maalala nyo, ano ba yung resting position ng AC joint? Okay, so dun tayo mag-lean muna. Alright, so, yan yung early phase ng rehab. Okay, if you had grade 1, 2, and 1, 2, or 3. Okay, ang ORIF nyo, magiging ganito ang itsura. Okay, yan na siya. So, this is the AC dislocate. Treatment, no, if it's type 1 to 3, no, usually we treat it yung pain para ma-reduce, okay, na ice or sling. Okay? And then we do aaron. And then isometrics lang. Okay? Para wala masyadong compressive forces, no? Isometric exercises for the clavicular attached muscles. Specifically, your deltoid and your traps, no? Syempre, ano yung mga specific fibers, no? Meron tayong specific fibers that attaches to the clavicle. Okay? Your anterior deltoid, tsaka yung upper traps. Okay? Yung dalawang yun. So, exercises to encourage scapular motion. Okay? So, pwede pa rin namang gumalaw-galaw si patient. Pwede pa rin niya igalaw yan. But, for the clavicular attached muscles, isometric exercises lang. Okay? Pero, if it's type 2 and 3, okay, kailangan muna 7 to 14 days immobilization. Okay? 7 to 14 days immobilization of the shoulder part lang. Ang elbow pwede pa rin galawin ni patient and yung kamay, no? Para lang maiwasan natin na merong unnecessary muscle atrophy. No? You would have to educate the patient that there needs to be still movements. Ang bawal lang talaga igalaw would be the shoulder. Elbow tsaka hand, pwede pa rin. Okay? But, no, pwede siyang galawin, but heavy lifting and contact sports should be avoided for 8 to 12 weeks. Okay, 8 to 12 weeks, no? Add ko lang pala with your clavicular attached muscles aside from the trapezius and deltoids would be your subclavius and pectoralis major. Okay? Subclavius and pectoralis major. Okay? Yan. So much for the dislocation. let's go to the rotator cuff injury. Okay? In your rotator cuff injury, no, ito. Ayan. Okay, almost the same lang, no? Ang nangyari lang dito, nag-strain yung muscle. Okay? Nag-strain yung muscle. We have rotator cuff tendinopathy. This is common cause of shoulder pain and impingement in athletes. Okay? Running, overhead activity, recce sports, and swimming. Okay? Due to distance and time, no, yun yung nagiging usual causes. Okay? Ng rotator cuff injury, no? In your history, no, pag tinanong nyo si patient, you would have the patient report of episodes of dead arm, no? Pag sinabing dead arm, ito yung parang ang bigat ng arm niya. Okay? Ang bigat. Or parang minsan hirap siyang galawin. Okay? Symptoms, no? Pain with overhead activity. Okay? Overhead activity. Tenderness over the supraspinatus tendon. So, dapat alam saan ang tendon ng supraspinatus. And the painful arc is at 70 to 120. Okay? Or 170 to 80. Okay? Yung dead arm na sinasabi dito, no, there is a sensory diminution or loss, okay, in the arm, okay, after the anterior shoulder dislocation or subluxation has happened. Okay? Yun, meron siyang sensory loss na kasama, yung dead arm. Okay? Ayan. Okay, for the treatment protocol of your rotator cuff injury, no, first part, no, you have to treat the tendinopathy itself, of course, no? Tendinopathy muna. Okay, so, patient should avoid aggravating activity. Okay, kung ano yung nagkakos, no, more of, usually, dahil ito ay due to overreaching activities, okay, contact sports, pwedeng si patient, mag-leave muna siya doon or avoid from, participating in activities such as that. Okay? Also, ice. No? Yan. Although, we have no concrete evidence to support your NSAID, ultrasound, laser, massage, and your interferential currents, no? The evidence supports the use of your nitric oxide donor. Okay? Yung nitric oxide donor therapy or yung GTN na sinasabi, no, these are patches, no, nandito sa picture di lang kita masyado, no. These are patches applied, okay, locally at about 1.25 milligram per day to the site of maximal tenderness. So, kung saan masakit yung if you're expecting rotator cuff injury, dun nyo siya i-attach. Okay? The patches remain for the skin for 24 hours and are then replaced. Okay? So, ibig sabihin, araw-araw siyang papalitan. Alright? Yun. So, dito, kailangan meron kayong thorough examination. Just make sure that it is really a rotator cuff injury. No? Hindi siya dislocation. Okay? So, right now, dapat medyo confident na kayo na pag may na-meet kayong patient with a proper assessment, no, you could identify kung anterior ba yan o posterior. AC joint ba yan o hindi. Okay? At least doon sa mga na-discuss na natin. And then, alright, a second part would be correction of the associated injury. Okay? So, after nyo ng pain reduction, okay, more of correction of associated injury. No? So, it would be your muscle weakness. No, you should address the muscle weakness, GH instability in coordination, soft tissue tightness, and training errors. No, yun yung mga may medyo nagkaka-problem na sa proprioception of the shoulder itself. Okay, so yan, training errors. Treatment protocol, okay, rotator cuff strengthening, na especially your external rotators. Now, if you had a rotator cuff injury, no, so external rotators naman ang papalakasin natin. Kanina, sa anterior disloc, ang papalakasin would be internal rotators. Different with rotator cuff, it should be the external rotators. And then soft tissue release, okay, still, no, just the same as yung na-discuss natin before with your AC, okay, your AC disloc, dito, we also would have to stretch the posterior GH capsule. So, dapat naalala pa din, no, horizontal adduction. Okay? Yan. This one, no, AC frozen shoulder, na-discuss na kasi natin siya, so skip na natin to. Let's go to the elbow injuries. Okay? Your elbow injuries, we have posterior dislocation and fracture of radial head. Okay, in your posterior disloc, this is a collision of an outstretched hand with the ground with elbow flex. No? Diba may push tayo? Okay. May sometimes nagkakos ng dito, posterior disloc of the shoulder. Okay. Ito naman, para rin siyang push, pero, okay, naka-flex yung elbow. Okay. Naka-flex yung elbow. Just like sa picture na to. No? Naka-extend yan, pero nag-flex. Okay, nag-flex yan eh. And then fracture of radial head, collision of an outstretched hand with the ground with elbow extended. No? So, siya yung isa sa mga combo ni Fuchs. Okay, si Fuchs kasi pwede rin siyang nagkaroon ng fracture of the radial head. Okay? Ayan. So, for your posterior dislocation of the elbow, hindi masyado kita sa picture, no? Ayan. So, one of the MOIs is your posterolateral rotatory force, your push. Okay, shoulder is abducted, axial compression. Okay, forearm is in supination and forced flexion of the elbow. Okay, forced flexion of the elbow. So, those are the MOIs of your posterior disloc. Okay, ito yung, ayan. Ito yung x-ray niya. Alright. Kung mapapansin ninyo, the ulna, okay, the ulna was displaced posteriorly. So, this is your posterior dislocation. Hindi dito masyado kita, no? It's more of, gusto lang pakita yung lateral deviation. Ito, posterior. No? So, you get the 3D view, okay, of what happened. Right? In your posterior disloc, no, ang medical management, okay, would be in reduction with the elbow held at 45-degree flexion, no, 45-degree flexion, the clinician grips the anterior aspect of the humerus, okay, and longitudinal traction along the forearm, no. Usually, may encounter nyo to sa mga bata, mahilig magkulitan, ay, mahilig magharutan. Okay? So, what you would do, maaalala nyo to if you, in case, have an encounter with this, no, nagkaroon ng dislocation, usually nangyayari talaga to, you hold the elbow in 45 degrees flexion, and then, yung anterior aspect of the humerus, okay, hahawakan ninyo, and then, maglo-longitude na, hahatakin nyo lang yung forearm. Okay? Elbow flex, 45 degrees. Okay? Hatakin nyo lang yung forearm while stabilize the anterior humerus. Okay? But if it incurred large fractures, of course, you will have to have the internal fixation. Okay? Unfortunately. Okay? Ayan. So, if you had the posterior dislocation, okay, kailangan mag-sling ka muna for 2 to 3 weeks. Okay? Yan. Immediate active mobilization. Okay? Kailangan may immediate active mobilization ka after the sling. Okay? And there should be a gentle joint mob. Okay? Your joint mob should be towards extension. Okay? Kasi pag meron kang long-term loss of elbow extension, pagka nagkakaroon ka ng posterior disloc, okay, usually ang nagiging problem ng mga patient na to is they have a long-term loss of extension. Okay, yun. Okay, yun nagiging kadalasan problem. Okay, next is strengthening of surrounding muscles, no? Surrounding muscles of the forearm. Okay, and arm. Okay, and then elbow stability taping. Now, we will be teaching you this during the laboratory. Okay. Next would be cumulative trauma. Okay, elbow soft tissue injury. Alright? So, we have epicondylitis, your UCL injury, and ulnar neuropathy. Okay? Usually, the etiology is throwing and racket sports, gymnastics, and basketball, no? Usually naman, pagka CTDs natin, these are injuries to your nervous or musculoskeletal system attributed to repetitive physical tasks or poor sustained posture or biomechanics. No, so those individuals who are exposed to repetitive stress will later on have this epicondylitis. So just like the rotator cuff, no, ang magiging approach natin dito is to let the inflammation heal first, and then we would further strengthen the weakened muscle and correct the training errors. Okay? Kasi ang problem dito, even though you would be able to uh, treat yung nagko-cause ng pain sa kanila, babalik at babalik yan hanggat hindi nako-correct yung training error. Yun ang pinaka one of the most important part of sports rehab, no? Yung correct the training errors. We have the lateral epicondylitis, medial epicondylitis, your ulnar neuropathy, and then the UCL. Okay? Yan. Let's have naman the fracture on the wrist and hand. Okay, wrist and hand. Scaphoid, no, most commonly siya yung fractured carpal bone. No, kasi, pagka nagkakaroon kayo ng push, no? So, usually, siya yung tumatama. Okay? Therefore, having the fracture. Okay? Pagka more proximal ang fracture, mas matagal ang healing time. No? Mas matagal ang healing time. And like what I've said earlier, no, pagdating natin sa wrist and hand, dito more of spica na yung application. More of spica taping ang ating treatment. Okay? Usually, no, pagka yung snuff box, okay, kung maalala nyo, to determine if nagkaroon ng fracture, no, sa scaphoid, pag pinalpate nyo si snuff box, okay, naalala pa ba paano hanapin ang snuff box, diba? It should be between the tendons here. Okay, yung parang box dyan, that's your anatomic snuff box. Okay, pag pinalpate nyo yan at masakit, sabi ni patient, usually the affected bone would be your scaphoid. And you would have to place the patient in thumb spica, splint for 2 weeks. Okay? If ORIF ang kailangan talaga, no, talagang wasak na wasak, alright? Kailangan ng ORIF, no? Although hindi masyado yung ORIF, no, lalo na pagka mga distal, hanggat hindi affected ang functionality of the patient, hindi sila ino-ORIF. Okay? Pero if ever i-ORIF ang patient due to scaphoid fracture, no, ang return to sports is about 3 to 4 months. Okay? Ayan, so parang ganyan siya. This is your snuff box. Diyan nyo siya ipapalpate. Okay, diyan din siya tender. Okay, and then this is your thumb spica. Okay, kumbaga, ikikip nyo lang siya in a neutral position. Okay. Okay. What if you had phalangeal fracture? No? So, kung ano man yung cause, no? Madali lang naman yan. Usually sa bola, pag nag-basketball, di ba? You do the body taping, no? Ito, maalala nyo pa. Kasi, ito sa pinakamadaling taping during your CPH, no? I believe you had the bandaging, basics of the bandaging already from Sir Pat, no? So, ayan, body taping. Alright? So, yung isa na fracture, okay, para medyo reduce or medyo ma-address yung fracture na yon, no? Pa-body taping na siya. Okay? Dun sa together with the normal one. Okay? Yung hindi affected. Okay? In your metacarpal fracture naman, no? Medyo usod tayo ng proximal. No? In your metacarpal fracture, middle and ring finger are more stable, no? Due to the transverse metacarpal ligament. Okay? So, if ever magkaroon ng metacarpal fracture, no, closed reduction and splinting lang ulit siya. Okay? About 3 to 4 weeks. And then, you do AROM exercises na. Madali lang. Madali lang AROM exercises. Even the other fractures, no, after splinting, AROM exercises ulit sila. Okay? Yan siya. So, this is your splint. Okay? How about dorsal dislocation of the PIP? Okay, pakita ko lang yung picture para medyo ma-appreciate nyo. Okay, ganyan nangyari. Mayroong dorsal dislocation or posterior dislocation. No? This is the most common dislocation in sports. And dito, no, body taping siya ulit. Okay? Body taping for 3 to 6 weeks. Okay? And a dorsal splint in 30 degrees of flexion. Okay? If hindi siya na-treat ng maayos, pwede kasi siyang magtuloy ng pseudobotonier deformity. Okay? Ayan. Okay? In your botonier, no, injury to the central sleeve of the extensor tendon into base of the middle phalanx. No, ito, usually due to trauma ang botonier ni patient, okay, you could do the splinting. Okay, about 5 to 6 weeks. Okay? And then, after ng volar or palmar splint, no, mag-shift kayo ng night splint. Okay, into 2 weeks. Okay, ito hindi na natin to masyado ma-practice. Pero ganyan lang siya, no? Kumbaga, ika-counter nyo lang yung mismong botonier. Okay? Yung direction niya. Mallet finger, or also known as the baseball finger, or drop finger, no? This is avulsion rupture naman, okay, of the DIP. Okay, avulsion rupture of the extensor mechanism from the DIP joint. Okay, so alam naman natin mallet finger, ito siya, ayan. Ayan. Okay, so ang treatment, another splinting, no? Okay. So, ika-counter nyo lang. No, madali lang pagka-finger, no? More on, ika-counter nyo lang yung kung saan siya na-displace. Okay? Jersey finger, no? Ito. No, mukhang bad finger, ah. Okay, with your jersey finger naman, etiology, avulsion naman siya of the FDP tendon. So, yung kung kanina nasa DIP, ito naman nasa FDP. Okay? Ito naman nakukuha in your forceful extension of the finger during maximum contraction of the FDP. Alright? Forceful extension. So, kung nakaganyan, no, forceful extension, okay, could result to jersey finger. No, ang symptoms niya, may swelling, pain sa palmar aspect, usually the ring finger, and inability to actively flex the DIP. Okay, although medyo mahirap, no? Kailangan nyo stabilize pagka ita-test nyo para ma-check nyo, no, kung meron siyang jersey finger. Wala. Yeah. Dito, sa jersey finger, no, wala tayong splinting. Alright? Walang splinting sa jersey finger natin. Gamekeeper's thumb. Okay, this is the most common soft tissue injury of the thumb. Okay, usually, isa rin to sa kasama sa MOI pag ang MOI mo is push. And dito, no, naka-thumb spike ka ulit. And this one naman for 4 weeks. No? Para di kayo malito, usually ang average ng mga splinting na yan is 4 weeks. No? 4 weeks. No? Sa lahat na, i-apply nyo na, no? Sa wrist and hand. 4 weeks. And then after that, arrow. Okay, para lang madalian kayo sa approach, no? Hindi na kayo mahirapan mag-memorize. Hindi ko na kayo papahirapan mag-memorize. Lahat ng ating spica casting, no, average would be 4 weeks. After that would be arrow. Kailangan lang malaman ninyo yung direction kung saan kung paano nyo siya i-correct, no? Kailangan nyo lang naman siya i-counter or i-put it in neutral position. Okay? Counter or in other words, put it in neutral position. In your scapholunate dissociation, okay, MOI, push na naman, okay, with excessive wrist extension and ulnar deviation. Okay? For this one, no, basta merong involvement si thumb spica ang sagot. Okay? Basta may involvement si thumb spica ang sagot. Okay? Okay? Now, let's go to the Decker veins. No, ito, madalas to mangyari sa mga mahilig mag-text, no? Mahilig maglaba. Okay? So, marami siyang other names. Your Decker vein syndrome, okay, is also known as your Wartenberg's, okay? Also known as your Hoffman's, also known as your Washer-Woman's, okay? Also known as your stenosing tenosynovitis. No? This is one of the most common tenosynovitis involving the APL or your EPB. No? APL or EPB. No, your abductor pollicis longus and your extensor pollicis brevis. Okay? Yan. So, clinical features, no, complaints of pain near the styloid process of radius, no, bandang dito. Okay? Kung maalala nyo, no, di ba, ang test for this one is to know if there is either veins is your Finkelstein test. Okay, so dapat alam nyo paano yung Finkelstein test. Okay, and you should know that it is a passive test. Okay? So, it's a repetitive, no? Isa to sa mga CTDs natin or cumulative trauma disorders. Okay? Decker veins. And usually, pag Decker veins, no, still involving the thumb, naka-spike ka siya ulit. Okay? Ayan. Spike ka ulit. Tapos, kailangan naka-neutral position siya ulit. Okay? ECU tenosynovitis. Okay? Ito hindi masyado, no? Pero, tennis players do experience this due to repetitive twisting and ulnar deviation of the wrist, no? Kaya during training of tennis, no, dun pa lang, ino-orient na kayo that the force should be coming from the elbow, not the wrist. Okay? Talagang magkakaroon kayo ng CTDs if you are using the force, using your force coming from the wrist. Okay? It should be coming from the elbow. Okay? Yun. Kasi, ang wrist motions lang, pang badminton yun. Okay? Meron pang badminton. Lastly, would be your trigger finger. Okay? Epidemiology, no, or case sports due to repeated grasping. No? Nagkakaroon kayo ng thickening of A1 pulley, yung nandito sa picture. Alright? And clinical picture, no, gradual and painless. No? Painless, pero very disturbing sa patient kasi may snapping ng finger, no? May kita nyo, may mga patient kayo, demo pa nila paano nagsasnap. Okay? Yun siya. And may kita nyo, merong nodular thickening. Usually, ang treatment naman dito, no, more of, ayan, no, po pwedeng surgical, pero syempre, ayaw naman nating mapagastos si patient, no, sometimes immobilization would do, steroid injection would do, and in clinics, minsan, yung paraffin wax bath, okay, arm exercises with that, flexibility exercises with that, and then ultrasound. Okay, yun, usually ginagawa sa trigger finger. Okay, pero mainly, ang treatment sa kanya is steroid injection. Okay? So, that would be it for today, no? Medyo maikli lang yung watch time, pero pwede nyong i-pause kung sakaling nabibilisan kayo, gusto yung mag-take down ng notes, you could do so. So, our references for this one, Brotzmann and Bruckner. Okay? Bruckner and Kat. No? So, silang dalawa. Wala tayong masyadong in-include na references dito na research, no? Kasi, more on sa lab na natin siya titignan. Okay? So, that would be it for today. For your post-quiz, no, mamaya, 30 minutes before the end time of our lecture session. Okay? Thank you and God bless.